Namaskar. Hello to all. Today we will discuss about early initiation with Empagliflozin and Linagliptin combination for optimal glycemic control in type 2 diabetes management. Evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complication of type 2 diabetes according to UKPDS study. Patients most likely to have a reduced cardiovascular disease risk with intensive glycemic control were those with a shorter type 2 diabetes duration who had not yet developed atherosclerosis. UKPDS study demonstrated a legacy effect of early intensive therapy because the difference in the CVE event rate 10-year post-trial was apparent even though no difference in HbA1c level between the intensive and conventional therapy. Early use of combination therapy in a patient with newly diagnosed type 2 diabetes shown to reduce the progression of atherosclerosis compared with conventional therapy. Real-world evidence has also shown a legacy of early intensive glycemic control in type 2 diabetes. For patients with HbA1c more than 1.5% above the goal at the diagnosis, American Diabetic Association and European Society of Diabetes guidelines recommend first-line treatment with dual combination and an SGLT2 inhibitor as the first post-metformin treatment in a patient with established cardiovascular disease, CHF, or CKD. For patients requiring additional treatment for control of glycemia, similar consideration should guide the addition of a third agent, which may include DPP4 inhibitor, if not on a GLP-1 RA or excluding sexagliptin in the setting of heart failure. The use of an SGLT2 inhibitor, GLP-1 RA or DPP4 inhibitor may also be added alone or in combination in a patient without atherosclerotic cardiovascular disease, heart failure or CKD if there is a need to minimize hypoglycemia. EMPA and LINA combination with complementary mechanism and pleiotropic benefit may be suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease or high-risk established heart failure or CKD due to tolerability of the combination, in addition to the potential benefit of empagliflozin on CV and renal outcomes, and no increased risk of heart failure with either agent. According to a study, early achievement of HbA1c goal less than 7% with EMPA or LINA could reach target. Following advice can be given to the patient while initiating this combination: maintaining hydration, perineal hygiene, adequate monitoring of body weight and blood pressure, blood glucose on routine basis, informing treating physician in case of symptoms of low blood glucose, follow the sick day rule. In case feeling sick due to fever, infection, poor appetite, nausea, vomiting, or diarrhea. Further evaluation in case of burning or pain during urination required. According to recent ADA 2022 standard of care, first-line therapy depends upon comorbidities, patient-centered treatment factors, and management needs, and generally includes metformin and comprehensive lifestyle modification. Treatment goal involves the control of glycemia and CV risk factor management and a patient-centered approach to care. The choice of pharmacological agent now considers the comorbidities in addition to the risk of hypoglycemia, impact on weight, cost, potential for side effects, and patient preference. Early glycemic control leads to better outcomes, including a reduction in long-term macrovascular and microvascular complications. For patients with inadequate glycemic control on metformin, addition of the single pill might be considered to help establish optimum glycemic control while reducing pill burden and avoiding clinical inertia in intensifying therapy. When metformin is not suitable and empagliflozin or linagliptin is being considered as an alternative first-line treatment, initial combination therapy may be considered to achieve target more quickly, particularly in a patient with 1.5% higher than target HbA1c level. It is reported that DPP4 inhibitors improve beta cell mass and function via beta cell differentiation and proliferation accompanied by decrease of oxidative stress and inflammatory cytokines. It is also reported that SGLT2 inhibitors improve beta cell mass and function via similar mechanism as DPP4 inhibitors, although the mechanism of glucose lowering defect is totally different. In experimental study, combination of DPP-4 inhibitor and SGLT2 inhibitor exerts more beneficial effect on beta cell mass and function, especially in an early phase of diabetes rather than an advanced phase. Empagliflozin is available as a first-in-class treatment in SGLT2 and DPP-4 combination group of drugs. At week 24, Empagliflozin 25/5 showed statistically significant HbA1c reduction, less than 1.08, and mean SD and baseline is 7.99%, and P is less than 0.001. That is significant. Add on to metformin. HbA1c decrements by Empagliflozin 25/5 mg combination has demonstrated 1.81% HbA1c reduction at HbA1c baseline if more than or equal to 8.5% 24 weeks. Change in fasting plasma glucose reduction with Empagliflozin was less than 32.2 at baseline and fasting plasma glucose of 156 at 24 weeks and maintained at week 52 in metformin treated groups. Higher percentage of patients achieving HbA1c less than 7% were reported for both single pill combinations, 61.8 versus 30.6, odds ratio 45.95, and confidence intervals 2.5 to 8.2, and P less than 0.001 versus EMPA 10 mg. Early achievement of goal, only fixed dose combination arm of Empagliflozin could reach target HbA1c at 12 weeks compared to monotherapies. The combination offers a suitable component in a strategy to achieve target HbA1c without hypoglycemia and weight gain. Additionally, it would reduce the daily pill burden in this population, potentially improving adherence to and optimizing the benefits of treatment of diabetes mellitus. Thank you.